The Plaque-Away Program, a DMP-led primary prevention program for geriatric adults with coronary artery disease. This program is going to discover the divergence, false impressions, reason for poor outcomes, and risk factors of the geriatric population to develop coronary artery disease. It will identify the impact of coronary artery disease around the nation, clarify the meaning behind the levels of prevention, primary, secondary, and tertiary, describe the Plaque-Away program and the interdisciplinary team behind it along with each of their roles, delineate prevention strategies at each level, outline a method to determine the success of the Plaque-Away program, and recognize the competencies needed by the DMP nurse to develop and implement the program. So geriatric adults, why are they vulnerable? They often reject treatment and medication to reduce their vulnerability to falls, malnutrition, or health decline because they see vulnerability as undermining their independence by having care forced onto them because they don't want to lose their autonomy just like anyone else. But this strive for independence can make them seem healthier than they really are and give them comorbidities that often go untreated. Social relationships, health and mobility, financial resources, social participation, and safe and pleasant neighborhoods can make a huge difference in the vulnerability of the geriatric population by decreasing it. Older persons often lack support and need care that they're not aware of by being surrounded by community because they isolate themselves, believing that they either don't need anyone's intervention and should suffer alone, or have already lived their life and have nothing else to live for, meaning that care is unnecessary. Geriatric adults lack quality of life because of oversupply of care and interference, poverty, exclusion from participation in society, homelessness, loss of autonomy and independence, institutionalization, and lack of social contacts and loneliness. 16.8% of America falls in the geriatric population category, and 10.3% of these fall in the poverty level. So as for morbidity, coronary artery disease is the second leading cause of disability in the geriatric population. And of this, 82% of adults over the age of 65 are actually killed by coronary artery disease. So what are some misconceptions of the geriatric population? Well, they're misunderstood. They're misspread that have normalized things that are really not normal in the process of aging. Older people isolate themselves, but that does not mean depression and loneliness are normal. This should be replaced with lifelong relationships. It is not normal to get less sleep as we age either. Yes, it may be harder to fall asleep and stay asleep, but 7 to 9 hours is still necessary for function. They're believed to not be able to learn new things, but just like all of us, older people can learn new things too. Cognitive changes are actually positive from life experience. We can all learn something new every day. They are seen to be weak, frail, and are told to take it easy and avoid exercise to not get injured. But longevity is actually increased with activity. They believe that they're too old to quit smoking. But it is never too late to quit smoking because quitting nicotine at any time can improve health. Blood pressure does increase with age, but if it becomes normal, medication should not be stopped. They should be continued because this could decrease the chances of comorbidities like stroke, kidney disease, and further heart disease. So those myths are depression and loneliness are normal, less sleep is required with aging, older adults cannot learn new things, older adults should take it easy and avoid exercise to not get injured, aging means quitting smoking is impossible, and blood pressure being lower or normal means to stop taking medication. So what are some risk factors for coronary artery disease in geriatric clients? Well, coronary artery disease is the leading cause of death in men and women aged 60 and over. The variables that were most significant in the studies of coronary artery disease in the geriatric population were baseline total cholesterol values, smoking, diabetic history, and presence of a carotid bruit. The results of the trials designed to test the interventions to control specified risk factors are the foundation of current recommendations for smoking cessation and the treatment of high blood pressure, high cholesterol, and diabetes. Rose angina, EKG abnormalities, uric acid, and fasting glucose levels are also important variables associated with coronary artery disease. So coronary artery disease risk significant variables are cigarette smoking, diabetes mellitus, atherosclerotic valvular disease, total cholesterol value, EKG abnormalities, and high blood pressure. So coronary artery disease is the second most common cause of disability in older people, and it is a major cause of self-reported poor health. It has been shown that coronary artery disease in adults aged 65 and over was associated with a loss of 5.6 to 6.5 years of quality life. So 55 and 98% of older adults aged 60 years and over have at least 2 chronic diseases. Only 17% of older adults with coronary artery disease have no other chronic conditions. Coronary artery disease frequently coexists with diabetes in about 37 to 47% of cases, with anemia in about 39 to 51% of cases, and arthritis in about 41 to 46% of cases. Polypharmacy, or multiple medications, among adults aged 65 and over ranges from about 26.3 to 39.9%, and on average, patients were treated with 11.6 plus or minus 4.5 drugs at home. Of adults aged 65 and over, 25% of those with congestive heart failure or coronary artery disease also had severe urinary incontinence or at least one fall. So chronic pain is in about 35 to 60%, sarcopenia in about 10%, delirium in 2 to 10%, depression in 0.6 to 2%, urinary incontinence in 2 to 25%, pressure ulcers in 3 to 10%, and falls in 20 to 40%. So poor outcomes for coronary artery disease in the geriatric population include angina or chest pain, because when the coronary arteries narrow, the heart may not be getting enough blood when on exertion, like exercising, causing chest pain and shortness of breath. Heart attacks, myocardial infarctions can happen because the cholesterol plaque could break and cause a blood clot to block the blood to the heart. This could damage the muscle, and the amount of damage depends on how quickly we treat the myocardial infarction. Heart failure. The narrow arteries in the heart or high blood pressure can slowly make the heart weaker or stiffer, so it's harder for the heart to pump blood. Irregular heart rhythms or arrhythmias. Because not enough blood flow can get to the heart, it can alter the normal heart signaling, causing irregular heartbeats. So the levels of prevention. There's primary prevention. This consists of measures aimed at a susceptible population or individual. It prevents the disease from ever occurring, so this targets healthy individuals, institutes activities that limit the risk exposure or increase immunity to a disease. Secondary prevention emphasizes early disease detection, is targeted at healthy appearing individuals with subclinical forms of the disease. Pathologic changes are occurring, but no overt symptoms are diagnosable. It occurs in the forms of screening, such as the Pap smear, and that can diagnose cervical cancer before it progresses. Tertiary prevention targets both the clinical and outcome stages of the disease. It's implemented in symptomatic patients and aims to reduce the severity of the disease, as well as any associated sequelae. While secondary prevention seeks to prevent the onset, tertiary prevention aims to reduce the effects of the disease. So what are some level examples of prevention? Primary, a heart-healthy diet, tobacco cessation, activity. Secondary would be blood pressure monitoring, heart catheterization. And tertiary could be cardiac rehab or stent placement. So prevention strategies at the primary level can include diet changes such as the DASH diet, exercise, physical activity, weight loss, so exercise about 150 minutes per week, tobacco cessation, high blood pressure management, cholesterol testing, or hemoglobin A1C testing. At the secondary level, lowering lipids with statins and those with CAD to reduce morbidity and mortality, low-dose aspirin in diabetic patients with an A1C over 7, metformin, Zetia, and for blood pressure management, ACE or ARBs. At the tertiary level, we aim to improve the quality of life by decreasing disability, delaying or limiting complications, and restoring cardiac function. This is achieved by treatment of CAD by rehabilitation. The team of the treatment is often comprised of physician, cardiologist, surgeon, exercise specialist, physiotherapist, dietitians, and nurses. It overlaps with those of secondary prevention. It includes stents, coronary artery bypass graft, pacemakers, defibrillators, and ventricular assistive devices. So the Blackaway program is a DNP-led primary prevention program centered towards the population aged 65 and older with risk factors for developing coronary artery disease. It's going to educate the geriatric and general population about the impacts of coronary artery disease, identify risk factors for coronary artery disease in the geriatric population to enhance their well-being, and to suggest prevention strategies to reduce the impact of coronary artery disease in the geriatric population. It's population-based, led by healthcare professionals with expertise in cardiovascular areas, helped run by volunteers from the community, and is beneficial to finances in heart health and illness prevention for the geriatric population. The interdisciplinary team consists of a D&P program director, cardiac specialists like physicians, nurses, and surgeons, a treasurer or financial planner, a program manager for marketing, a nutritionist for cardiac dietary counseling, a tobacco cessation counselor and support group coordinators, personal trainers, and educators from the community. So the D&P is responsible for the outcomes, evaluates further needs and goals met within the community, develops plans of care, creates the policies for the program, and constructs a well-organized team. The surgeons and physicians are responsible for taking the clients with low income and evaluate them with severe risk factors for possible invasive interventions such as bypass grafts. The nurses are to monitor blood pressure, run cholesterol labs, and hemoglobin A1C as needed. The financial planner is going to coordinate the funding. The program manager is going to publicize the program and generate creative ideas. The nutritionist is going to counsel on proper diet. The tobacco cessation counselor is going to monitor progress toward smoking quitting. And the personal trainer is going to demonstrate proper exercise to strengthen the heart. And the community educators are going to teach geriatric clients in general terms about how to improve health. Now, D&P competencies necessary are organizational and systems leadership, which eliminates health disparities and enhances patient safety while focusing on the needs of a population in a holistic manner to balance productivity and quality of care. We also need healthcare policy for advocacy in healthcare because that facilitates delivery of care and treatment and allows the provider to participate in their practice to meet needs in healthcare, and then policy development to create a system that meets client needs. So to measure program success, we're going to use modifiable risk factor reduction outcomes, activity recommendation outcomes, dietary adherence, stress reduction outcomes, tobacco cessation outcomes, blood pressure measurement outcomes, follow-up care percentage, participant satisfaction, and financial debt percentage. So we're going to reassess clients by a health assessment at the primary healthcare follow-up appointment 6 weeks after completing the program to look at the risk factors compared to before, have participants keep an activity log or step count to assess 1 month after, keep a food log of their dietary intake of meals and eating habits for 1 month after, use a D&P prepared stress quiz to have participants fill these out before the program and then again 1 month after, ask the tobacco cessation counselor how the clients perform with cessation during the program and have them work with them for another week and assess them again 6 months after, have clients take their own blood pressure at home and keep a log and return it to the 1 month appointment after, contact to schedule follow-up appointments with the participants and count how many come to the appointments, have participants complete an evaluation survey at the end of the program to assess satisfaction, and ask the treasurer how to count the fund and denote if funds were overspent. So did modifiable risk factors decrease? Did stress decrease? Did participants attend follow-up appointments? Were the participants satisfied? Was tobacco cessation helpful? Were the funds adequate? Were blood pressures adequate? Was dietary intake healthy? And did activity increase? Are the questions we're going to answer. So in summary, the geriatric persons are identified as a vulnerable population. 3 levels of prevention need to be considered within the practice of a D&P: primary, secondary, and tertiary prevention. The Plaqueway program aims to educate the geriatric population, along with the general population, about the impacts of coronary artery disease, identify risk factors for coronary artery disease in the geriatric population and enhance well-being, suggest prevention strategies to reduce the impact of coronary artery disease in the geriatric population. Competencies necessary in programs led by a D&P are organizational and systems leadership, healthcare policy for advocacy in healthcare, and measures of success include modifiable risk factor reduction outcomes, activity recommendation outcomes, dietary adherence, stress reduction outcomes, tobacco cessation outcomes, blood pressure measurement outcomes, follow-up care percentage, participant satisfaction, and financial debt percentage.